on the important things we are going to mention today. Um, so I'm going to talk quickly first about the head injury, and I'm not going to record lectures because I want to be sure people who attended today they have the privileges of being on time and attending the session. Um, so head injury is quite common, and usually it's defined as acute physical damage to the brain as a result of an external forces. We define the head injury in general as either a closed head injury or open head injury. The closed head injury when the dura mater is intact, and I assume you guys all know what does dura mater mean. It's the layer covering the brain. It's called dura mater, and if that's opened up, that's indicate the open head injury. And usually the dura is covered with the skull, then gallia, then the skin. It's common in children, and children because they have frequent fall, teenagers and young adult because of RTA and road traffic accidents, and finally on older patient because also they frequently have a attack of fall down, more common in male than in female. And if we are going to talk about the etiology, we all know the motor vehicle accident is the most common one, followed by falls, gunshot, and finally the sports. Uh, Here is a really important principle you have to know and understand. Okay, and this is the first things apart from the division of open and closed head injury. This is the second fundamental thing I want you guys to get from this lecture. Okay, and it's talking about the pathophysiology um, of head injury. We get head injury either from first hit, from the direct impact on the skull, on the brain, and we have, and this is could be happen from mechanical, from blunt, from penetration, um, and then we have the second hit. So the unfortunate thing, the first hit or the first trauma, this is we unfortunately we can not, there is nothing we can do about it because the damage has already happened um, to that part of the brain. Um, but on the coming hours and days, there will be a chance of getting a second hit and injury to the brain, and that's happened from releasing of inflammatory mediators, from hypoxia to the brain, from acidosis, from coagulopathy, and these consequences could cause more secondary second hit to the brain, and that can cause ischemia, brain edema, increasing the intracranial pressure. And the goal of um, we are trying to achieve from managing the head injury patient is to prevent the second hit. Okay, I hope this principle is clear for you guys. Anyone have any question about the this principle of first hit and second hit at the cause of head injury before I move forward? Perfect. Thank you. And good. Perfect. Sorry. And um, this is another important things when we get a primary head injury. The injury, it can be focal, and this is happen from direct on the side. If someone get hit on the, for example, right temporal bone, he will get a fracture of the right temporal bone, contusion of the brain underneath his, or hematoma. Okay. Apart from the focal injury, what's called the contracope. Contracope, that's mean when you get hit on the right, or for example frontal lobe, then, or when you get a hit on the occipital bone, then the brain will shake and hit the frontal bone, and that's called contracope. So if you get hit from the back, the injury to the brain, it will be in the front, okay, and the opposite. And the other thing is the diffuse axonal injury, and this is happen usually when we have a acceleration or deceleration injury, and that's usually happen with a high speed motor vehicle accident, when the people driving too fast and then suddenly they hit something. There will be a very quick deceleration, and that will cause shearing injury in the brain cells, and that will cause diffuse brain injury, and that's what cause brain severe head injury and deep coma for the patients. Okay, so that's another important second principle. Nothing to don't focus on this um, um, on this slide. Apart from diffuse axonal injury is a sign of severe traumatic brain injuries, and it's happened with a high motor vehicle accident from acceleration deceleration, and that usually those patients will be in coma for a while. Okay, and usually they don't need medical treatment, surgical intervention. And in terms of the clinical features, and this is a straightforward, um, there is a global symptoms. Those patients could present with headache, amnesia, decreased level of consciousness, dizziness, nausea, vomiting, seizure, sensory disturbance, cranial nerve palsy, anything you can imagine. Okay. Um, Two things I need you guys to focus on this slide specifically. It's the Cushing triad, and I did not write it down, but it's for you to Google and you for you as an homework. This is a triad. That means it's three clinical presentation: hypertension, bradycardia, and respiratory irregularity. Okay, and that indicate this patient Cushing triad: hypertension, bradycardia, and respiratory irregularity. And this is basically indicate this patient has is herniating. Herniating. This is herniation. It's happened when the pressure in the brain is really high, and part of the brain herniate through the foramen magnum. Foramen magnum, that's the bottom of the skull, where is the brain stem run and connect to the spinal cord. So when the part of the brain herniate on that place in the foramen magnum, there will be the bottom of the brain stem, and there will be a medulla oblongata. And the medulla oblongata have the respiratory, cardiac control spot. And that's why if there is a compression and herniation, the cardiovascular control will be disrupted. This patient will have a hypertension and bradycardia, and then the respiratory system will get disrupted, and those patients will get respiratory irregularity. And if those patients did not get treated immediately, or those patients will die, and basically they will arrest either cardiac or respiratory. Okay, so I hope guys you recognize this, because if you are a maxillofacial surgeon and you are treating a patient with multi-trauma patients, and they have a head injury patients, you guys all know, if the patient has, for example, hypotension, that's indication this patient in shock and most likely bleeding somewhere, isn't it? But if the patient has a hypertension, which is the opposite, and bradycardia, which is opposite to the shock, it's a hypotension and tachycardia, then that's indicate this is a brain insult and brain herniation. Okay, that's why I need you guys to focus on this thing. The second one, it's not really important, because it's usually um, something happen in a patient with a mild head injury. But it's important to know, if you treated a patient with a facial fracture and they're following in your clinic, and they have a history of, headache, being and fatigue, dizziness, some cognitive decline, depression, sleep disturbance, we see those symptoms in post concussion syndrome. Concussion is a mild form of head injury. Sometimes they can get post concussion syndrome and chronic symptoms of those symptoms I mentioned for couple months and weeks. Okay. I hope this is a clear, the Cushing triad and post concussion syndromes. It's not uncommon, if the patient had a bad maxillofacial fracture, to have base of a skull fracture. Okay, and when you have a base of a skull fracture, then you could have a tear in the dura, and when you have a tear in the dura, then the C-safe could leak, and this leak, it can be through the ear or through the nose. Okay, so a C-safe leak, it's something you have to know, and you have to recognize clinically, because you could have a patient with a facial fracture as well as base of skull fracture, and clinically, usually it's a clear like water. um, if it's mixed with the blood, and that could happen, if you put it in a gauze, then you will see what's called halo sign. The blood will be a circle, then will be a circle of water around it. That's what's called halo signs, and it's important for you guys to know. Okay, they could have associated cranial nerve palsy, seventh and eighth, if it's skull base of fracture on the lateral skull base. Okay, and it could be olfactory mostly, if the anterior skull base. Okay, this is another important thing. And if it's lateral skull base, usually we get battle signs, which is a redness we will see later behind the ear, and raccoon's eyes if it's anterior skull base. This is also, again, it's important to know the raccoon's battle signs as well as the halo signs. And because certainly, if you're going to practice maxillofacial, you can see those kind of patients. You have to know them, because if it's get recognized, you have to talk to your neurosurgery colleague, um, neurosurgery colleague, because they need to intervene. Sometime we do a lumbar drain. You don't have to know all this, but just to know, you don't have to know the managements, but you have to know the sign and clinical pictures. And if you pick them up, you talk to your neurosurgical colleague. They try to treat those safely with many things. Sometimes they put lumbar drain. If it's failed, then they take them surgery, and they need to be covered with antibiotics. Okay, So recognition, that's what I need from you. Don't worry about the management in anything I'm talking to you about today. Okay. And in general, this is, I'm sure many people talk to you about, is the general approach to treat the patient with traumatic brain injury or trauma in general. Okay. First, we have to stabilize the patients. Major life support should be given. In trauma, we are doing based all the protocol on the acute trauma life support, ATLS, and we have to do APCs. A is the airway. Okay, this is the first thing you have to be sure it's protected, especially if they have if your patient have facial fracture. Okay, or a mandible fracture. Okay, protecting the airway is a must. If the airway is open, the patient is talking and awake, that's mean he's maintaining his airway. He doesn't need anything, any intervention. If the patient has really bad maxillofacial fracture and you are worried about the edema and bleeding in the mouth, even if the patient is still awake and maintaining the airway, sometimes we do the intubation to protect the airway as a prophylactic measures. Okay. The third thing, if their level of consciousness is low, and usually we use eight, if eight's and low, the Glasgow Coma Scale, which I will talk about, that indicate the level of consciousness is low, then those patients should be intubated because they by default they will not be able to maintain their airway. Okay. And I'm not sure, guys, if you have if someone give you a talk about Glasgow Coma Scale before. Yes or no? Perfect. So usually it gives you an impression how bad is the injury, mild, moderate, and severe based on the score. So I will go quick on them. And um, um, this is another thing which is really, guys, you have to keep in your mind and know, because apart from airway, which we talked about, then breathing, which is you want to be sure this patient doesn't have a catastrophic thing affecting his breathing. Catastrophic thing, what I meant is uh, tension pneumothorax, hemothorax, flail chest, anything compromising the breathing, and patient in hypoxia. Because if you have this, then you have to address them. If it's tension pneumothorax, you have to put a needle. If it's a hemothorax, you have to put chest tube, and you have to protect their airway too. And third thing is the circulation, and I'm sure someone give you a talk about the circulation and trauma again, and that's you're gonna be sure the patient is not hypotensive, it's not tachycardic, and if it's hypotensive tachycardic, you have to look quickly where is it could be the the patient, where is he bleeding? It's in the abdomen, it's in the chest, if it's in the femur, and you have to start to get him a lot of fluids, and then followed with the blood and defining with the sort of bleeding and treating them. So A, B, C, those are the most important thing. Then after that is E and D and E, disability and exposure. And this is when it comes when it the neurosurgical and head injury and spine um, issues should be picked up and treated. So it gets summarized in a quick, what we call it, rapid trauma and neurological examination. We look at the level of consciousness, and we, based on the Glasgow Coma Scale, to pick up that. We look at the pupil, which is really important and critical. Okay. The pupil, it's like a stethoscope for a medicine, or it's like, your drill you guys using in dental work. It's really important and clinical. We look at the pupil. Normally, when you shine a light, and the pupil should constrict, and that indicate your optic nerve and the kilometer nerve are working and fine. If there is a pupil asymmetry, one pupil is bigger than the other, okay, or if the one pupil is not reacting, That's indicate most likely the third nerve is compressed, and that's an indication of another herniation. Okay, in the tentorium, where is the third nerve is running. So basically, when you have a pupil asymmetry, pupil is not reacting, pupil is big, then this is really important neurosurgical urgency, not even emergency, it's an urgency. You have to call your neurosurgical colleague. Okay. um, Other things it come next. It's not as important as a level of consciousness and pupil. You don't, you just know them, don't know about a lot of details about them. I mean, you want to check the eye movement, extremity movements, because if he's not moving hands, if he's not moving legs, you could think about the spinal cord injury, either cervical or dorsal or lumbar. You want to see the response to pain. You want to see their plantar response and brainstem reflexes. Plantar response, that will give you if the patient is spinal shock or not. Brainstem reflexes, it's important because that's gonna determine the outcome. Because unfortunately, sometimes we get a patient who's really in late stage, who has really bad brain injury. To a degree, he lost all his brain stem reflexes. And what I mean by brain stem reflexes is pupil is not reacting, and patient doesn't have cough reflex. Cough reflex, if you put anything in the mouth, the endotracheal tube, patient is not coughing to it. Okay. Um, and those, when they are absent, that indicate this is already bad injury, and most likely, uh, and sometimes we say it's definitely this patient unfortunately will not make it. And that's kind of give you a hint. If even if he has a maxillofacial fracture of bad injury, you have to keep in your mind this patient is not gonna survive, unfortunately, and he will not go and get any intervention from any sort. Okay. So um, head injury and spinal injury, or specifically head injury, if it's too bad and get picked up early and get managed, those patients could survive. If those patients came too late, then you have to be aware of what's called, you know, early signs of brainstem death. And those patients usually we will be treated palliatively, and they will not get any further treatment. Okay. So bottom line, you can just know this list quickly, but focus on level of consciousness and the pupils because they are really important. Okay. And you guys, I'm sure you know this. So it's written there. We defined a Glasgow coma scale based on the motor. If the patient obey commands, get 6. If patient localized to pain, when you pinch him anywhere, he will localize and grab your hand. That's 5. Withdraw, um, he will remove his hand from the pain. That will get 4. Flexion to pain, 3. Extension to pain, 2. Nothing will be 1. And eye opening, if it's opening spontaneously, 4. 4 is 3. Pain, 2. None, nothing. Verbal, if he's oriented, 5. He's confused, 4. Inappropriate word, 3. And incomprehensive, 4. Words, 2. And none is 1. And then collect them, get your score, and that will tell you if it's mild, moderate, or severe. There is a little variation between adult and child, and the variation it's on the verbal. Okay, because the kids not necessarily in early age will be able to talk, so that's the variation for the infants and young children. It's on the verbal part. Okay, you don't have to focus on the children, but just know this: you have to focus only on adult. Okay. And um, there are a couple of differential diagnoses for um, pupil being abnormal, but ignore this slide. It's quite complicated, and I don't want you guys to know this Because what I know you to focus on is when you have a pupil asymmetry or pupil not reacting, call neurosurgery, have a suspicion of bad head injury, and leave going through differential diagnosis to the neurosurgery team. From this slide, what I need from you is if there is abnormal in the reflex, and it's something I think it's important, to be done in trauma at some point, not on the first thing, no, later on when everything settled down. Then, if there is abnormal reflexes or asymmetry, keep in your mind this patient might have a spinal shock, might have spinal cord injury, might have head injury. That's what I need from you. Those three words. If there is asymmetry in reflexes, or if it's abnormal, it is hypo or exaggerated, then this patient could have head injury, spinal cord injury, or spinal cord injury and then a spinal shock. Is that clear? Perfect. From this slide, we have to know CT scan is the standard and the standard of care and what we order in trauma. Okay, because it can be done quick in seconds, in less than a minute, and it gives you all the details you want to know. If there is a hemorrhage, if there is a bleeding, epidural, subdural, if there is brain contusion, if there is brain edema, if there is a fractures, it gives you all the data you need. Okay. And the second thing, MRI, it doesn't need to be done on acute stage. Never ever. It can be done later for prognosis, doing confirm the diagnosis of diffuse axonal injury. And cerebral angiogram, it can be ordered if we are thinking about vascular injury. Okay. Hopefully this is clear too. Um, I think up to slide 17, you have to comprehend and understand all the things I focused on. From here and moving forward, most of it talking about management. It's nice for you guys to know in general, but it's not really critical for your exam. It's not really critical and important for your managing your patients. But the clinical presentation and diagnosis is important because you might be the one facing the patients, and you want to be sure you don't miss anything of this injury, and this patient could have a complication. In general, what's could injured in the head? It could be the scalp, in the skull. It could be vascular injury. It could be penetrating. It could be epidural. It could be subdural. It could be subarachnoid, or it could be intracerebral. And the intracranial hemorrhage divided based on location. As I said, you have a skull, then you have a dura. If the bleeding above the dura, epidural. If it's underneath the dura, it's subdural. And then between the dura and the brain, there is two layers. There is arachnoid, which is a thin layer, translucent, and then pia. Pia, it's also a thin layer covering the brain. And sometimes the bleeding subdural or subarachnoid, between the arachnoid and pia. And finally, intracerebral hemorrhage, it's inside the brain. So it's really important to know this scheme. It just when people talk about kinds of bleeding, then you'll be, oriented and alert. And this is just simple, straightforward. Skin or scalp injury, it could be simple, it could be complicated. If it's simple, can be treated easily in ER. If it's extensive, degloving, effulsion, then those patients might need to go to the OR to close the scalp in a better way, especially if there is a bad fracture underneath it. Okay. Um, and second things is the skull fracture. So we finish from skin, then we'll come to the skull. Skull, it can be open or closed, and that's based on the dura, if it's open or closed. Fracture, it can be simple and linear, it could be bad and comminuted, it could be the aesthetic, it could be the breast pushed on the brain, or it could be in the base of a skull. Those are just the type of skull fracture. But in general, if it's small, not open, not depressed, nothing to be done. If it's bad, depressed, open, I mean dura is open and everything open, then it has to be treated surgically. You go in, you open everything, and you clean, you close everything, and that's it. You don't have to know about the surgery at all, but just you have to know. For example, if you are in a place you don't have a neurosurgeon, for example, and you have a patient with maxillar fracture, and they have skull fracture, and then, just for your knowledge, if it's a simple, not depressed, not badly communicated, it's not open skull fracture, then there is nothing to be done. Those patients will be treated conservatively, and they don't even need a neurosurgery service. Okay, that's in general. But the opposite to that, no, they need um, intervention. You don't have to read about this details in this slide. I mentioned, guys, before the base of skull fracture, and I think it's important to know because there is a strong association with the maxillofacial fracture, and that's what I talked about. The raccoon's eyes, when the fracture in the anterior skull base, battle signs, okay, and that's when the fracture in lateral skull base, and this lateral skull base will cause C-safe leak through the ear, otorrhea. Anterior skull base usually will cause C-safe leak through the nose, rhinorrhea. Okay, and you can see the dripping of the fluids, like and we talked about the halo signs as a diagnosis. um, Second things is the epidural hematoma, and usually it has this shape because it's above the dura, and this is in general, you can see many patients with the epidural hematoma. And in all hematoma in general, if it's small in size, patient is awake, doesn't causing mass effect on the brain, thus is not causing any neurological deficit, it is not increasing in size and follow-up images, all those can be treated conservatively without any intervention. And in general, if it's big, if it's affecting on the level of consciousness, if it's causing neurological deficit, if it's progressing in size, those patients need to be treated surgery immediately. Okay, so if you have a patient who has any kind of this presentation, it should be sent as a life-saving refer, and after talking to the neurosurgery team, informing them about about your patient. You don't have to talk about about the details. There is important clinical things you have to know. Sometime in one third of the patient, they will have what's called lucid interval. um, um, they decrease level of consciousness, then they become awake, and when you see them, you said, oh, those patients are fine, then they progress, unfortunately, and deteriorate neurologically. And in those patients, you have to be careful, not taking it lightly, and refer them to the neurosurgery. Okay, you don't need to know this is for your information, it's not in the exam, but what I mentioned about the size and level of consciousness, that's what push you for surgery. Okay, and you don't have to know about the surgery, but this is for your, for your own information. Basically, you open the skin, you open the skull, evacuate the hematoma, and put everything back. Subdural hematoma, it's the same principle, but it's located underneath the subdural hematoma. And you have to keep in your mind, subdural hematoma, usually they have a worse prognosis than epidural hematoma because usually they have associated brain injury. Okay, that's the important notes and information you have to know. The same principle of surgery. You don't have to know this. Subarachnoid hemorrhage, also it's not important. Intracerebral hemorrhage, we see it quite sometimes, especially in old age. And the indication for surgery, again, it's the same one. If the patient has a bad neurological sign, if the hematoma is really large, if they are not awake, then those patients really need a neurosurgery service. If it's mild hematoma, mild brain contusion, hemorrhagic contusion, still you will take neurosurgery opinion. But what I'm talking about is about the urgency. Okay, when you say, "Oh, I have to leave everything in my hand, talk to the neurosurgery team, and get this patient on the road," because delaying a surgical pathology or surgery in a patient with a hematoma, that's basically um, could end with death or bad neurological outcome. Penetrating head injury, again, um, it's something I will not focus on too much because it's rare in all over the world. But unfortunately, because of Yemen war, it's quite common here in Jazan because of gunshots to the brain. And sometimes we guys share some injuries. Soldiers come with a bullet going through through the facial bone, going through the brain, and crossing over and coming out from the skull, or landing and landing in the brain somewhere. And in general, for those patients, what they need is, it can be just simple debridement at the entry and exit point if the patient is um, fully awake, alert, they don't have a bad bleeding in the brain. And usually this is happen when they have there are different kind of guns. There is a guns with a low velocity and chance of injury, and there's a guns which has a high velocity and higher chance of damage, and it depends on the material of the bullet itself. And two, if the a guns was if the patient get hit from a close distance, or if it's from the far, usually the injury is really minor. And sometimes patient, they have a gunshot to the brain and they're fully awake and alert, and they're completely fine, and those patients not necessarily will need any intervention. And a matter of fact, we don't go in the brain and try to pull out or remove the bullet, because sometimes removing them, they can cause more damage to the brain. Okay, we do surgery when the bullet causes significant hematoma and the patient has a low significant mass effect in the brain and the patient has a low GCS. Then we go with treat them, evacuate the hematoma, clean everything, and manage their high intracranial pressure. But the bottom line, and that's what we do in our ward as a neurosurgery and penetrating head injury to the brain with a gunshot. Usually we don't go after and removing those bullets. I'm not sure about the maxillofacial. Maybe it's the same principle. Okay. So that's what you need, guys, to know about the penetrating head injury, focusing on the bullet because it's quite common here. Usually we do just debridement for the penetrating side, unless patient has a big hematoma, big mass effect, decrease in left heart consciousness. Then we go after the hematoma. We don't go after the bullet. Mild head injury, don't worry about it. You don't have to know them. We talked about the severe head injury in general. Um, um, Sometime just to keep in your mind, um, in severe head injury patients, those patients could have high intracranial pressure, either from brain edema, from the hematoma, and sometimes we put what's called external ventricular drainage, which is basically through a small hole all the way directed in the ventricle. It helps us to measure the intracranial pressure in the brain, and because high intracranial pressure, that's mean high, that's mean more pressure on the brain, that's mean more brain damage, more secondary hit to the brain. And sometimes we decrease the intracranial pressure by draining some fluid, as you can see in this bag. And usually we like the intracranial pressure to be less than 20. Okay, so those the two important things you have to know, because as I share with a maxillofacial, we share some patient together, and if you stop by and see your patient who had a maxillofacial fracture and you see a drain coming from the brain, that's the external ventricular drainage, and they measure the pressure and decrease the pressure by relieving the CSF, and the normal value of intracranial pressure, it should be less than 20 in general. And why we using it? Because this is just principle, what's called Monroe Kelly doctrine principle. As you know, the brain inside the skull, it's a closed space, and you have CSF, you have brain, and you have blood. If you put anything else like brain edema, you bleeding, that's gonna compromise other part of the brain. Sometimes we try to compensate by any chance, and if we did not compensate, then it get into a life-threatening herniation, causing triad and death. It's important to know this principle in general, and how bad head injury and bleeding in the brain could kill the patient, unfortunately. That specific measure, we do it um, to manage a patient with high ICB. For you guys, I need you just to know. I don't need you guys to know all those details, because it's a bit um, um, you will not be guys doing it, but somebody else will be taking care of it. But simple things you have to know, for example, elevation of headbit by 20 to 30 degree. This is important to decrease brain edema. This is you have to keep in your mind, because this is simple, straightforward. If you've had a patient with a head injury, please, okay, if you come and assist him, don't put him in a flat position, or don't get him completely sitting 20 or 30 degree. Okay, always we try to put a bladder fully catheter to decrease their straining. And three, we give them anti-seizure medication. So those three things, it's really basic and important for everyone to know. Forget about everything else. Okay, we talked about this is something to keep in your mind. Unfortunately, some patients with severe head injury, their mortality reached to 30%. And also this is to have and to keep it in your mind, because as a maxillofacial surgeon, when you are treating a patient, you want to know their prognosis, and if they have a head injury, you want to know, and if they have a good prognosis or no. And usually the sign of bad prognosis is, for example, pupil asymmetry, old patient, bad CT scan with the bleeding and ischemia and subdural hematoma in compared to epidural hematoma, absence of brainstem reflexes, bad GCS, high intracranial pressures. So those are the thing. If you have it in one patient, then you have to keep in your mind, this patient is really sick. I should not intervene. I should not fix his mandible. I should not fix his maxilla. I have to wait until storm go down, patient settle down, know about the prognosis, and if this patient is going to make it, give a opportunity to treat the high intracranial pressure and head injury. Okay, so this thing on the red, this is all a sign of bad head injury. Okay, so I think this is an important slide you have to know when you are deciding about when to treat your patients, when to treat the facial fracture, and do your maxillofacial work. It's clear. um, Ignore the rest of this because I talked about before. Age, older age is the worst prognosis. That's the sentence you need to know from this. um, Another thing is hypotension. um, Hypotension, also bad prognosis. Hypoxia is a bad prognosis. Delay in treatment, prolonged transport, delay surgery, also bad prognosis. So you have to know this because those are really important. Okay, and usually that's what I'm trying, guys, to encourage you to do is, uh, if you have any sign or clinical sign or symptoms, those patient might have head injury, so rapid transport to a trauma facility where there is a neurosurgery service that can be provided, quick resuscitation, airway, breathing, circulation. Do your CT scan quickly, and if there is an acute hemorrhage, need intervention, then refer the patients to the facility where is the neurosurgery service. And by this, I finish my talk. If you guys have any question, you either raise your hand and talk, or you can type in the chat. Head position 20 to 30 degree. This is for Ahlam. Um, yes.